Well, welcome everybody. My name is Kenley Money. I am with the Arkansas All-Payer Claims Database that is part of the Healthcare Transparency Initiative. To begin, a little introduction. This is our 9th Data Users Group session, the October 2021 quarterly APCB Data Users Group. For those who are new to these sessions, the Arkansas APCD is part of the Arkansas Healthcare Transparency Initiative and is administered by the Arkansas Center for Health Improvement. You'll see ACHI in the upper right-hand corner there. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims. Additionally, the HTI, or the Healthcare Transparency Initiative, enables the use of key data sets from the Arkansas Department of Health, including Arkansas Vital Statistics data, hospital discharge and emergency department data for their self-pay and uninsured patients, cancer registry data, and medical marijuana card holder data. We hope you find today's session helpful. We invite you to ask questions at the end of this session and/or reach out to our team after, and you can ask questions after each topic as well. We'll take any question. So without further ado, let's go to the next slide, Jennifer, and look at our agenda. Today's agenda was developed using survey responses from the last data users groups. We get our best feedback from you. And the topics include, yes, thank you. The question is, will the recording and material be available after? We're about to get to housekeeping. We'll just do it now. So yes, this is recorded. That recording and the deck will be published on the Arkansas APCD website. Everyone will receive a follow-up email and that will have that information and some other information as well. So absolutely. All right, the agenda today includes 3 primary topics: methodologies for quantifying race ethnicity assignment in Arkansas Medicaid data, which is part of the APCD. Methodologies for using member IDs versus APCD hash IDs. We've talked about that a lot, but we need to talk about it again. Methodologies for using cancer data for colorectal cancer and other screenings, something new and exciting. And we always like to follow up with the latest APCD release information and data tips, and of course, question and discussion throughout. So some housekeeping, to reiterate just a little. Between each section, at the end of the whole session, we'll ask for questions. Feel free to type your questions in the chat. Clearly, you're already doing that. We'll address them between and before transitioning. At the end of today's session, we will provide a link to our service desk application where you can enter any other question that you think of after today. APCD data can be complicated. You can also request time with our team to address specific questions you may have about how to use or interpret the data. And as I said a moment ago, the link to this deck will be provided in a follow-up email. Finally, the next Data Users Group session is scheduled for January 26, 2020. That is also in this deck, and you'll hear about it again. Why don't we go to the next slide? So this is our team. You've heard from me before, Kenley Money. Dr. Nicole Sanders will speak on the first topic. We've heard from her before, and she always provides great information. And we have a new analyst with us today, Sarah Crawford, and she will be talking about the colorectal cancer screenings. Next slide. Okay. In years past, we've just used a regular survey that we sent out after the session. Last time we used a new tool called Mentimeter, an interactive presentation software, and we're going to use that again. So there are slides placed in the beginning and the end of the presentation to capture participant feedback. Last time we did it, if you went to the last data users group, we had these feedback questions throughout the whole presentation, and it was not an efficient use of time. So we're just going to get a little information about our guests here now, and then at the end, we'll ask for some feedback for the whole thing. So let's go to the next slide. This gives us some instructions. So on your phone, and I'm going to do this with you, on your phone or in a different browser, I'm not sure how you're watching this, go to menti.com and it will give you an, I'm not sure how it will look depending on what you're using, phone or browser. It will give you a box that says enter code to vote. And you'll see in just a moment, Jennifer's going to change the slide. Not yet, Jennifer. At the top of the slide, there'll be a phrase like that's in this blue box here that says that's the reference code. The code in this box is not the code for this session. You'll see that in just a moment. Enter that code in the menti.com box where it says enter code to vote and hit the go or the submit button. I can't remember exactly what it says. And then the question will pop up. So let's go to the next slide. And our code is 66254447. And this question will show up on your phone or browser. So to begin, we want to know about you. Would you please name your institution, your role, faculty, student, and you can enter it as many times as you want, or there are 3 options there. So I see you, I'm sure a lot of you are from UAMS, ACHI. Great, great. Yeah. Analyst, senior data analyst, wonderful. Submit. Staff evaluator. Data geek. Decision queue, great. It's awesome. Biostats. Great. Let's wait a couple of more. Wonderful. Okay, so why don't we go? Well, we're still getting on. Okay. 10 more seconds. Okay, that looks pretty stable, I say. Let's go. Jennifer, why don't we go to the next question? And on your screen, everybody, you should see next question. And this is a yes, no answer. You didn't have to renew the code, so just start answering. Great. Very nice. "23 people. I can't remember how many are attending, and admittedly, I did answer too. So that sounds pretty good. So why don't we go to the next question? And your screen should change when Jennifer changes. All right. What is your analytic skill level? Don't be shy. Good. Wonderful. That's good. Okay. Why don't we do the next question? Okay. You should be able to enter more than one. Like I said, it's very complicated, these data. -19, 23, looks like 23 is the number. Great. Excellent. Well, thank you, everybody, for being patient and answering these questions. Like I said, there'll be a couple of more at the end. Let's move on to our next topic. Oh, we're still in. Okay, great. 25. Cool. All right, let's move to the next topic. And we're going to turn it over to Dr. Nicole Sanders. Nicole, are you there?
I am. Can you hear me?
Mm-hmm.
Okay, I'm talking at Mike's desk, so that's me, by the way. All right, so let's go to the next slide, Jennifer. Thank you. So the APCB claims-based data includes 2 race and 2 ethnicity fields in the enrollment file. However, some of you may know that submitting entities are not required to submit these fields. They are optional. At the moment, I can't tell you how many submitters do submit other than Medicaid, but I know that I think there are a couple. Medicaid only submits ME021, which is race, and ME025, which is ethnicity, and uses the codes that are listed in the appendices, Appendix H for race and Appendix I for ethnicity. So we discovered an issue with Medicaid ethnicity in the 20D build back in July, which has now been corrected, and I'll discuss in a little bit. But in the 21B build, that has been corrected. And also you can get more information about this particular issue in the tip sheet. So how we found the issue was because we found a large percentage of unknown races. Next slide, please. So here are, and let me say, like the number of, or the race categories that are used, these are federal codes, and they can get very, very specific. There's possibly over 1,000 codes. I haven't counted those, so. Here you can see these are the only codes that Medicaid actually uses. You can see that we have nearly a little over 19% of the individuals or the beneficiaries are identified as unknown. We don't know why this is. Is it because the data wasn't collected appropriately, or perhaps individuals elected not to indicate a race, which wouldn't be that surprising? We had hoped to mitigate this situation using ME025. A lot of studies typically combine race and ethnicity because of general data quality issues. Not everybody reports or collects them separately, etc. So we planned using the logic of, we planned on using the logic that if ME025 indicated Hispanic, then we'd assign Hispanic. Otherwise, we'd use the race that was identified in ME021 and create a new combined race ethnicity field. And at that point, we realized that ME025 had been hard-coded to either 35 or 34. Jennifer, can you show Appendix I real quick? Yes, okay. So let's scroll down a little bit to get like as much as we can, particularly 34 and 35. Okay, so these are the general codes where we have either not Hispanic or Latino, or Hispanic or Latino, or unknown, with each of those with either other race or no race indicated. So everything, the majority of individuals were coded with a 34, I believe. And at any rate, you can see that that's a problem. So we did talk to Medicaid and they corrected the issue. So the field now actually includes nearly, if not all, of these categories. And you can see that most of the categories, there's either Hispanic or Latino in any of the races that are listed. Unknown ethnicity in any of the races, and not Hispanic or Latino in any of the races. So let's go to the next slide, please. Here is a selection of the breakdowns, which includes counts for 34 and 35. And this is after the correction, of course. This is what's in 21B right now. And unfortunately, 35 unknown, other, or blank race is 17% of the total. However, I crossed my fingers and created the combined race ethnicity field, and the breakdown for which you can see on this next slide is that I apparently was overly optimistic in my hope that unknown ME021 might have a known ME025. As you can see, we are a little over 18% unknown race and ethnicity combined. So with that being said, we are currently in the early stages of investigating other sources for race and actually other social determinants of health to supplement the information that we have in the APCB. And of course, we will keep all of you abreast of any further developments. And that is all for me.
Nicole, this is Kenley. There are a couple of questions in the chat.
Yes.
The first one is, can persons be multiracial?
So they could be, if you use the ethnicity field, ME025, you can, and I did do this, you can run your frequencies on that. You still have the problem of most of those being unknown though, or not most, but 20%, nearly 20% being unknown. But they have things like not Hispanic and Latino with the race of Black and white. A lot of that's there. Let's see. So yes, they can be multiracial. The unknown for the ethnicity, yes, it can include more than one race. And because if we're talking about race and unknown ethnicity, each of those, like, they're two separate fields. So obviously, a race that's, any of those races can be assigned with an unknown ethnicity, and any of the unknowns can, of course, be assigned with a ethnicity, which unfortunately appears to be only in 1% of the cases. Let's see. So in federal circles, race is distinct from ethnicity. That is true. Why code them together as opposed to keeping them distinct? Because, and I've been doing this for many years now, and we have always hoped that the federal circles having distinct race and ethnicity, separate fields, would get picked up by other data collection institutes, and that is not the case. So we have to make do with what we have. And one of the cleanest things to do is include ethnicity and race together. Okay, are there other questions? This is just really good information here in the comments, in the chat.
Yeah. Can everyone read the chat? I'm happy to read it to you, but it's very good information.
Very cool.
So, yes,
actually,
it is hard to, go ahead, Nicole.
I was going to say that, Dr. Martin, I don't think it is on medical claims.
It is not.
It's not.
It does, yeah. That's an interesting source. Perhaps we can find that somehow.
Yeah.
If we ever got the medical record, the electronic medical record.
Ooh.
That would be good.
Fun times.
Yes, indeed. Wow. Forgive us while we geek out here a moment with our data. Great conversation. Any other questions? If not, we'll move to our next topic, and you're welcome to continue to put questions and we can address them at the end. So, all right, the next topic is methodologies for using member IDs versus APCB hash IDs. And I'm going to cover this for us today. Next slide. All right. The Arkansas APCD team receives more questions on this topic than most others. Therefore, we wanted to spend some more time on it as part of this data users group. The information we are covering here is included in the data user support document found on the APCD website. You see a link for it here in the bottom right. When you get the deck at the end of this meeting, this link will be live so you can go there. This deck, the highlights in it should help you not only find the information in the resource document, but provide a good foundation for using data once you start your projects. So let's do, the next few slides are my quick summary of the information in that deck. All right, go back, please. Jennifer, she got ahead of herself. All right, so let's look at this slide to begin. Enrollees and individuals are connected in the following ways across data types. They're within a carrier or payer, across carrier or payers, or between claims-based and non-claims-based data. So if enrollees, when you look at enrollees within a carrier, it tracks enrollee experience in that one payer carrier over time. Otherwise, it across is tracks the enrollee's experience across different payers. And then the last one is when we want to associate the Arkansas APCD claims data with the other HTI data like birth certificates, death certificates, etc. Now let's go to the next slide. I gave you a badge. So distinguishing individuals, there are two key data elements used to distinguish enrollees. One is the enrollee ID, sometimes called the member ID. It has a lot of names, and it in the claims-based data, it is in those fields listed there, ME 107, MC 137, that's medical claims, PC 107, pharmacy, DC 056, dental. And in the non-claims-based data, it's there are many names for that ID. But in birth certificate numbers, death certificates, patient control numbers, file or case numbers, etc. And then the second field is the APCD unique ID. And that's the hashed version of the concatenated last name and date of birth for each individual enrollee. And we do it for both claims-based and non-claims-based data. So a lot of you are familiar with this, but I feel the need to build this foundation as we review this information. So we have the enrollee ID, AKA member ID, and the unique APCD unique ID. Let's go to the next slide. Let's talk about connections within a payer. A picture speaks 1,000 words, and the graphics on the next few slides are intended to illustrate how the different IDs work and how to use them. But first, we must establish some terms specific to connecting APCD individuals to aid in these illustrations. These terms align with previous presentations about collision management and are commonplace in the ACHI analytic and data use protocol, analytic team and data use protocols. And all these presentations are out on our website. So the first connection term is SEID, SE_ID, and this term represents the concatenation of the following two fields, the entity ID and the enrollee ID. And the entity ID is the alphanumeric code that represents a carrier or payer within the plan claims provider. For example, if you've used the data at all, there's a field that's consistently numbered on all the file types, ME001, MC001, PC001, DC001, and the value in that field represents the carrier. For example, 83470 equals Blue Cross Blue Shield. So you take that Blue Cross, that 83470 and that entity ID field, and you concatenate it with your member ID, enrollee ID, and that is the definitive ID within that carrier. But because enrollee IDs or can occur across different carriers. That's why you have to concatenate them. In the example there, you can see I could have member ID 123 on Blue Cross, and Jennifer could have member ID 123 on QualChoice, and we don't need to join without including the entity ID to distinguish them. There are some gotchas though, of course. For example, if a group uses a TPA to manage their medical claims and a PBM to manage their pharmacy claims, and yet something else to manage their dental claims, the likelihood of all of them having the same member ID is remote for the same people, especially with PBMs. So that's when you have to look at your hash ID and to look at connections across carriers. And in this picture here, this VIN represents the SEID joining the claims for that, the experience for that person across all those file types. Next slide, please. Same VIN, but we're going to focus on the purplish diamond at the tops, AKA study ID. So the study ID, you've probably heard about this before. The question is TPA is a third-party administrator, not TPM. Sorry about that. I should have defined that. Anyway, the study ID is the concatenation of the APCD unique ID, which is found on the member record only, ME998, and gender. That creates the study ID, AKA hash ID. And that's its nickname. So think about it. The unique ID is the hashed version of a member's last name and date of birth. And then you concatenate that with the gender. And that is a pretty clean identifier or connector. You can't back in to know who the person is based on that information. You can't decipher the hash ID. But you can find the experiences for that person or that member across carriers using it pretty well. It's only problematic. It's in small tests we've done, it's about 97% effective. Twins can be problematic. Very generic names with the same date of birth can cause issues. But the collision presentation we did a couple of beta user groups ago will help you work through all of that. Anyway, so again, the APCD uniquity is found only on the member enrollment data. Therefore, the study ID can only be created there. And then you sort of have to chain to find it. To link or connect enrollees across carriers or payers, you have to find the enrollees with the same study ID within the plan data. And then once that linkage has been established, use the SEID to find the associated data on other file types. Note, individuals can have multiple study IDs across a single SEID because of name changes and data quality issues. So you have to think about that as you move forward. Now, all of that sounds like stereo instructions. Let's look at an example. Next slide, please. Okay, in this example, we have a couple of different things. You'll see there is the entity ID and the member ID or enrollee ID that make up the SEID. And then there's the study ID in the next two columns. So in this case, there is a member with the member ID 12ABC 244. There's another member 3995026 6204 and then you can see the unique IDs, and there are a couple of similarities, and then there's the gender, and you'll see the NA like on row 2 and 4 medical claims NA under study ID, because remember that it's not on the claims records. So you could approach this chaining, if you will, this way. And Nicole's done this 1,000 times, and she probably has a better way. But we're going to start here because you have to start sometimes with a few more steps just to grasp the whole thing. So you find the claims that match the enrollment member records of the SEID in number 1 and 2. So we know that this person is within 83470, which is Blue Cross Blue Shield. There's a member record and a medical claims record. Well, is this only, so the comment is this only is 2 different real people? Maybe, we'll see. So you find that claim. Then you find the other enrollment member records within the same carrier that have the same study ID, but a different member ID. So your study ID, if you look at row 3, it's the same study ID, but it's got a different member ID. Sometimes that happens. Sometimes a person comes in after a period of time and they get a new member ID for some reason. Then you find the claims that match those records based on your SEID. And in that case, we're still at rows 1, 2, 3, 4. You have to look at some other data to determine if this is the same person. And it probably is, but you need to double check. So you need to look at things like overlapping enrollment periods. If these 2 members, even though they had the same study ID, had the same enrollment periods, but a different plan name, probably different people. But if they had subsequent study ID, enrollment periods with the same plan and same zip code and the same types of medical claims, it's probably the same person. So at that point, you have to determine how important is it to be able to bring all of these experiences together. Do you need all of that? Do you need that minutia of uncertainty? But we've done it a lot and it works pretty well. So then, to find other enrollment member records that connect on the study ID, you find the others that connect on the study ID, then find the claims that match. I guess we were there. So if you go down to rows 5 and 6, you see the same study ID. And again, there's another member ID, but it's another carrier altogether. So this is an example of PBMs and TPAs. 99CAR happens to be Caremark or CVS Pharmacy, and they're one of the largest pharmacy benefit managers in the state. So most likely this person, based on the study ID, their pharmacy claims are managed through Caremark, where their medical claims are managed through Blue Cross Blue Shield. So then you get down to row 7, which is weird. So row 7 has the same member ID, the same SEID, but a completely different study ID. The gender's the same. So what has happened, quite possibly, is that this person changed their name. And a female, she got married or she got divorced, her name changed. Remember, it's the concatenation of the last name and the date of birth. And so her study ID changed. So you have to apply the same type of process to that. You grouped on the member ID or the SEID. Is it the same enrollment? Is it the same plan? Are the medical services the same? So there are some decisions to make in there about the data that's provided to determine if that's the same person. Now, while the hash ID is not PII, certainly it's not quite as clean as a social security number. If we had full PII, because we don't, you would still have to address a lot of these same questions because data quality can disrupt that. But we have found over the years, we've been doing this now for many years, if you go back and look at the collision management logic, you can build a very effective analytic data set, even when you have situations like this that make member records look like different people, and so that you can appropriately associate their claims with them. So it is entirely possible that this is 2 different people, but I don't think so. You would have to look at the other data that's related to it. All right, so let's go to the next slide. Connecting to non-claims based data types. you would use the study ID, get the study ID off of your APCD claims, and then go get the study ID, create a study ID on the non-claims data. So they will all have the APCD unique ID, and then, let me finish and then I'll go back and answer your question about row 7. They all have the APCD unique ID and they all have gender. So you can create a study ID and then you can start joining that way. Again, you need to look at time periods and, you know, if you have and places. So I had an example in my head, but you do need to be sure to look at other data that supports the match to help give a clue that it's the same person, but it works pretty well. Thank you for that, William Winkler. So let's go back, Jennifer, to the previous slide. So how do you find row 7s? Well, if you can find row 7s by grouping on your SEID and looking for study IDs that are different. So, and then once you find that, then you would look at the other supporting data like enrollment periods and plan names and types of medical services to determine if that's the same person. So let's go to the next slide. Next slide. All right. So this is, I won't read this whole thing to you, but this is sort of an illustration of how you can link. And steps 1 through 7 could help you think through how to link data across 2 different carriers and some of the vital statistics data using your study ID. Lots of information without a lot of concrete clues. All right, next slide. In summary, this is just some reminders. Use the SCID when connecting enrollees within a carrier payer. The study ID, use it across carriers payers and across the claims-based and non-claims-based data. And use the study ID when connecting enrollees within a carrier payer when grouped by key data that represents a single enrollee. Use SCID when connecting enrollees within a single payer when grouped. Yeah, I don't need to read that to you. You can read it yourself. But it should be that should be helpful, hopefully, along the way. All right, that is the end of mine. Are there any questions? And we're going to invite you. I'll invite you now and we'll invite you again. If you want to talk about this in more depth, feel free to reach out to us and we can schedule some one-on-one time. Does study ID include birth date? Well, it can. Sometimes now remember the birth date is inside the hash, the APCD unique ID or hash ID, because it's the concatenated date, last name and date of birth. So sometimes we do include birth date when we create the study ID though, because we did find at least one carrier where sometimes the medical claims system was different than the member system and a birth date was different. So sometimes we do that. It doesn't help a lot, but every now and again. The next question is, do you have a list of issues to watch out for? I wrote down twins, generic names with the same dates of birth. We have a doc, actually, I think it's in the collision deck. Tell you what, we'll send the link to the collision deck as well, and it will help with that. Okay, yeah. I'm making a note. So remember, I will say this before we move on. Issues to watch out for, and you could, that assumes that the data is clean. There will always be issues. The minute if on plan A, my name is spelled M-O-N-E-Y, and on plan B, my name is spelled M-O-N-Y, that's an immediate problem that we have no control over. So, yeah, gender is becoming more complicated. Right now, you know, I don't know the answer to that question because we instruct, the question is, gender is becoming more complicated. Is it only male, female in the APCD? So what we do is we instruct the carrier to concatenate the last name and date of birth. Okay, I'm thinking out loud. The gender in this case is whatever gender is on the record. So it could, and in the APCD, it's only MF and U. So took me a minute. Which is best for counting unique enrollees, SEID versus APCD? Nicole, are you still there?
I am indeed.
Can you answer that question?
Yes, I can. It really depends on what your study population is made of. Are you only looking at, say, pharmacy claims for a single year? You want to count the number of individuals in there. Then a CID is going to get pretty close to the actual population, because there could be people that switched pharmacy coverage types in the middle of the year. Study ID will get you probably even closer. We almost always use study ID for counting, and we never use the APCD unique ID because you really need to concatenate it with gender. One interesting thing to point out, though, is that when we create our study IDs, we keep the most recent SEID record, like the information that's on the most recent SEID. That's what we use. So we typically don't have an SEID with more than one study ID on it.
Yeah.
But yeah, we almost always count just study IDs.
Good tip. Yep. All right. And let's move to our next topic. Methodologies for using cancer data for colorectal cancer and other screenings. And I want to introduce to you Sarah Crawford. Sarah?
Hi, can you guys hear me?
Yes.
Okay. So ACHI is partnering with researchers at UAMS and the Department of Health and others to update our statewide cancer profile and related analysis. Back in 2011, our center conducted an assessment of some of the most prevalent cancers among Northwest Arkansas residents. We focused on 4 counties in that part of the state. We're now doing an updated version of that analysis at the county level, but for the entire state. Our objective is to look at incidence, prevalence, and stage of diagnosis, mortality, and screenings for the cancer types we're interested in. We're using the cancer registry data along with the APCD data and linking those sources. And we're focusing on 5 types of cancer. They're breast cancer, lung cancer, colorectal, prostate, and cervical cancer. Next slide. So this slide, we have a Venn diagram of the primary data sources we're using for the analysis. From the APCD data, we can derive information from claims about screenings, costs, treatments, and where care was received. And we are looking at that for the whole state. From the cancer registry, we can assess all of the indicators that you see in that middle circle there, including the incidence, stage of diagnosis, other indicators, prevalence, and getting that information on that. When we link the APCD and cancer registry using, the methods that Kelly just talked about, using the unique ID and stuff, we can look back at care received by those cancer patients, those individuals diagnosed with cancer. We can look at them in the APCD data, and we can look at any potential disparities by coverage source and race and ethnicity. And then finally, we can use the hospital discharge data to get the complete picture of hospital utilization, including any utilization among uninsured individuals. Next slide. So this is an example using the colorectal cancer. We have the incidence of colorectal cancer by age in Arkansas in 2017. As you can see, we had about 1,500 cases that year with a substantial amount of new diagnoses among even the 40 to 49-year-old population. The guidelines at that time around screening for colorectal cancer were for those aged 50 to 75 to be screened. That has since been updated and will go into effect for 45 to 49-year-olds next year in Arkansas. You can go to the next slide. On this slide, we have an example of our colorectal screening analysis derived from the claims data. We looked at individuals aged 50 to 75 who had continuous enrollment for evidence of utilization of the various stool-based tests and follow-up colonoscopies. And this was done in the context of 45 to 49-year-old individuals now being recommended to receive screenings. This analysis is part of a specific colorectal cancer analysis in partnership with a national advocacy group called Fight CRC. We did this earlier this year. You can go to the next slide. So some key considerations when using the cancer registry data. We started using it this year kind of for the first time as in-depthly since probably 2011. So we've learned a lot about the cancer registry this year. The cancer registry lists by tumor or incidence, not by individual. So individual can be listed like as having breast cancer twice in the same year, just because it's a incidence database, not based on just by individual. When identifying patients with cancer, with the cancer of interest, you want to use the SEER recode variable instead of just looking for like a diagnosis code. They do have diagnosis codes in there, but the SEER recode is going to be giving you the best information on the cancer you're looking for. The last date that's in the cancer registry is either the date of death or their last date seen for cancer-related follow-up. So for things like survival analysis, you're going to want to use that last date and cause of death to determine if the patient has passed. So if they haven't passed, they'll have a last date, but they won't have a cause of death. You can go on the next slide. So for staging, in the cancer registry, there's 3 different variables that can be used depending on the year that you're looking at. And those are listed there, and you'll get this so you can see them later. But it makes things a little more complicated than just pulling one variable, but it's not too bad. To determine prevalence, we use a 5-year time period for each year in question. So it's like a 5-year look back to determine prevalence for a single year, just because we don't have like infinite years going back. So, and then age weighting can be done on incidence using the US standard population. And I have some links in the next slide, which you can switch to. That'll show you where you can go for information on that. So you'll receive all these, and there's a lot of good information at those websites too, regarding those little tips. And that's it for our update on our cancer analysis. So we can take any questions if you got some.
That's great, Sarah. Anybody have any questions? Please enter them. None? Good. You can still answer. Let's move on in the interest of time. A time check, we have 7 minutes. Is it published? There's a question, Sarah.
So what we're working on currently, the big one, it is not published yet. We're still working on that. It probably will be, I think, maybe another year, because there's all 5 of those cancers and it's just a lot going on. But
yeah, I think that's
gonna
going to be a year out.
Yeah.
Yeah. Okay. The next to the last section, after this will be the final feedback slides. This is the latest APCD release information. We'll get to that question in just a moment. So next slide, I'll try to get through here so we can talk about more specific questions. So the APCD has been refreshed. It now has data through December 31st. Every time we refresh, we publish new release notes that are about that particular update, and they are at the link here. There's not time to go through them now, but after this, you can go and select them. They include overall coverage dates, source-specific release notes. Sometimes they're problematic submitting entities. Sometimes if we've omitted submitters in the past that are now included, but all of that will give you a good picture. Next slide. And don't forget, whenever you use our data, don't ever forget to go to our data tips. Next slide, please. So also data dictionaries, there are tip sheets and some highlights. Be sure to review them all. You'll the broken record here. Some resolved issues, the 3 there, the top one is subscriber date of birth and age for, this is a carrier called HealthSmart. The subscriber date of birth was all 9/9/12/31, and that's been resolved. The data submitted all of its data. The next one, issue 0016, it's a United carrier and their hash IDs were incorrect, ME998, but that's been resolved. They resubmitted all their data. And then the last one listed here of the highlights, the problematic APCD ID values for Cigna, that too had an issue. In fact, I think in that one they were missing. That's been resolved. If you have data that was pulled from us prior to January of 2020, you would take a second look at this, and if your data has these issues, then you could, and they're problematic, they may not be. Not many people use the subscribe line. Then you can reach out to us and we can help you with a workaround. And then some new things that you should be aware of in these data for the new build, tip 0087, inpatient and institutional definition expansion. For Medicaid specifically, there are several fields in the medical claims that were for inpatient only. And we found that to be incomplete, meaning that it's omitted things like long-term care, and yet they use the same types of code. So Medicaid has started it, and in the current build, these fields, if you go to this data tip, it'll help you identify the fields. Now also include institutions, not just inpatient. And when next year, end of next year, 2022, we're going to start getting more data from carriers, other carriers with this same change. The next one, issue 0080, Delta Dental open enrollment segments. We found out some time ago, it's been about 6 or 8 months, that there was an issue with the Delta Dental enrollment data because they changed systems and they didn't update the data to include the new member IDs. So we had individuals with lots and lots of member IDs, SCIDs. And so we had to use the hash ID a lot. Anyway, that's all being repaired. And we've gotten new data, and it won't be it's not in this bill, the one that we just released, but in the next bill, we hope to have it. And then the last one is a tip, identifying duplicate claims across carriers. Periodically, we have found that we missed, you may receive, let me say it a different way. You may receive data where claims are submitted by 2 different entities. Here's what I mean. Let's take EBD, our Employee Benefits Division data. We get their medical and pharmacy claims data from the state, and we also get it from their third-party administrator, Blue Cross Blue Shield. So there are ways to identify if the claim is duplicated, and meaning that Blue Cross submitted a claim and EBD submitted a claim for the same thing, for the same person. So there are already tips in the tip sheet that talk about that, especially that specific one. But this tip right here goes more into depth about that. So sometimes if you're looking at utilization and you're grouping claims and you wait, that looks exactly the same, but it's different because it has a different SEID. That is why. So let's go to the next slide. Technical support. If you have questions about data requests, data use, pricing, use that ADRS link. Otherwise, go to our support desk, ask any question. We are here to help you and respond. And remember, if you want a one-on-one with us on a particular topic, we're happy to accommodate. We've invited folks for a couple of data users groups and no one's taken us up on it. So maybe it's good. Maybe you can use your data. Maybe that's great. I think then if that's the case, then we want to learn from you. All right, so it is time. Next slide, please, for more questions. In our remaining, we are at the hour. Well, let's go through this real fast. If you guys have 2 more minutes overall, and remember, 6, put in your code if you haven't already. How would you rate the presentation? And don't be scared. You can say whatever. Okay. 7. Okay. I'm going to move on. Not just right. How likely are you to use the APCB? You can call us, use those links. We're at 11. Let's go to the next one. In the interest of time, if you would like, just send us an email at one of those 2 links. That'll be fine. But if you have something on top of mind, just pop it in here. No. Okay, why don't we move, Jennifer? And same thing. How could I do hope that I'm sorry about the time. I do hope you respond to that because we get our topics from you and we can only do better with your feedback. All right. Let's move on. I think, and then would you be interested in a one-on-one meeting? Most everyone's probably dropping off. So. No, that's okay. Well, all right. I'll reiterate. Use the 2 links, the 2 email addresses. Reach out to us. We are here to help you. This is complicated stuff, and we can help, and then we can learn from you. So let's go to the next slide. And without any further ado, remember January 26th is the next data users group. And thank you so much. Thank you. 3 minutes over. Have a great day.